It is with great pleasure that I introduce Dr. Mike Kattan. Dr. Kattan is the chair of the Department of Quantitative Health Sciences in the Lerner Research Institute at Cleveland Clinic Foundation, where he also serves as a professor of medicine and biostatistics, epidemiology in Cleveland, Ohio. Welcome, Mike.
It's great to be here. Thanks for having me.
Thank you. So I think before we get to your recent manuscript, the predictive modeling, which is in public domain about COVID-19, I'd like you to please explain to our viewers and listeners today a little bit about your background, how you got to do what you do at Cleveland Clinic.
Yeah, it's great. It's a crazy story. It was not plan A, as you would say, but I was pre-med as an undergraduate, thinking that's what I wanted to do. And I did a little internship with my family doctor back in the day, between my sophomore and junior years of college, I think, and saw, what he had to do for a living. And I realized I can't hack that. I'm in this for all the wrong reasons. And this is not what I excel at. And what I really like is programming computers and quantitative analysis and calculating things and numbers and formulas. So I switched gears at that point, and I ended up getting an undergraduate degree in food science and food chemistry, which was just a bunch of math and chemistry, hopefully setting the stage for a medical school career. Then I was going to get a master's degree in computer science because I thought that's where I belonged. But to do that, you have to have an undergraduate degree first, and I didn't want to backtrack that way. So my advisor said, you should go get an MBA and specialize in quantitative information systems and things of that nature, which they have that exactly so I did that, then was talked into, you should just go get a PhD and head down this path. First, so I'm in the business school. I'm getting a PhD in the business school in management information systems, with a minor in statistics. And my first year in the program, I got night sweats. I was sweating at night. I had no other complaints. I called my doctor, who was my mom, and she pulled out the Merck Manual Home Edition and said, I need you to feel your armpits. Do you feel anything there? No, I have nothing there. All right, great. I need you to feel around in your neck. And I said, yeah, there actually is a kind of a rock sticking out of my collarbone on one side, and it doesn't hurt, but it is there. I don't have a rock on the other side. So long story short, I ended up having Hodgkin's disease. I'm in Houston, Texas at that point, and I had, no other problems other than the sweating at night. Nothing hurt. I wasn't even tired. And it turns out I'm stage 4B, Hodgkin's disease. Didn't catch that early, but it opened my eyes to the fascinating realm of medical decision-making and specifically medical prediction. I got very frustrated because I was in the business school studying prediction of bankruptcy and stock prices and all sorts of financial outcomes, where if the goal there is predictive accuracy, and if you can just predict a little bit more accurately than your competitor, you stand to make a lot of money, and that's the goal. It's all about predictive accuracy. You go over to the medical side, and it's like, oh, you're a stage 4, but you're not really a stage 4. You're kind of more like this, and it was all loosey-goosey, and I'm trying to figure out, gee, am I likely to live? And the approach was way too casual for me there. So that kind of launched me into this this quest for more precise prediction for medical outcomes. I quickly lost interest in all financial things, and I've been on this mission to drive prediction modeling in areas of medicine where it's controversial. So that by luck, I was still in the business school. I met someone who gave me a postdoc at Baylor College of Medicine in medical informatics to help with the transition. Then I quickly met the chair of urology at Baylor College of Medicine, Dr. Peter Scardino, who basically hired me to do medical decision-making in urology. And so that's when I started doing all sorts of prediction models where it's the perfect setting. It's a very, as you well know, it's extremely controversial from soup to nuts. You know, who do you screen? Who do you treat? If anyone, and lots of controversy there. So it's really a nice field where medical prediction can help with decision-making quite a bit. So it just led to my passion for trying to make the most accurate prediction tools that we can anywhere in medicine where it's controversial. Like you struggle with, do I do A or B? There's trade-offs. That's what I listen for. And that's the projects I jump in on, is a trade-off involved, because that tells me that's an area where accurate prediction can really have an impact and drive behavior there. So that's how I got started doing this.
Well, thank you for sharing that very personal information with us. It certainly explains some of the passion and the high quality you do. Somewhat reminiscent of my younger son, Trevor, who also was pre-med and then got fascinated by numbers and ended up going back to Penn for his master's in artificial intelligence and machine learning. And
I get it.
Yep, very similar.
Get it.
Similar story. Yeah.
Yeah.
So if you could perhaps share what, in my opinion, you might be best known for is your prostate cancer nomogram, to explain that to people as a background to the one for COVID-19.
I jumped into this arena of prostate cancer, many years ago, and I saw that basically men were being counseled with tools that I felt were primitive and of the nature that I encountered when I was looking for outcomes with Hodgkin's disease. And they were just sort of some crude risk grouping systems, or some folks would count risk factors or look for a single feature, that identified who was at high risk. And they were just, they drove me crazy, because they were, oh, if your PSA is over, pick a number, 10, you're in big trouble. But as long as you're under that, you're fine. And just these rules of thumb that were just terrible from the standpoint of predictive accuracy, which is what I really cared about and what I looked at first. And so I saw that what was going on was they would have these, or they'd have some trees, you drop the patient down a tree. Well, if your PSA is greater than 6 and your biopsy result is so-and-so, then you're in this bucket, and you would quickly sort the patients into these low, intermediate, and high risk groups. Once again, not the best thing to do if accuracy is your goal, because you get apples and oranges in each of those buckets. And who cares about the bucket? I care about me. Where am I in this bucket? Being a favorable stage 4 patient, I was in a very bad bucket, but on the favorable side of the bad bucket. So I was looking for ways to approach the problem that were just different, that put accuracy first and not the goal. I hated these papers where our goal is to find risk groups. Those drove me nuts. It's like, no, why? That's not really it shouldn't be your goal. Your goal should be to accurately predict the outcome that you care about. If that's via using risk groups, then great, but it's probably not going to be. So you shouldn't, launch with that kind of goal in mind. So I was studying the literature, then looking for what's the best way to approach the problem if accuracy is your first priority. I found that to be the approach with nomograms, and typically with regression models and equations like that were not, as friendly to use. At least the nomogram's not bad, but they're not as friendly as something you can memorize on the fly. Oh, at first I look for this, and if he has this, I look for that. It doesn't work that way anymore. And we can talk about that on the COVID stuff too. But my favorite approach in terms of accuracy was typically a regression model, maybe a machine learning approach, but it ultimately is a formula that weighted the various factors, and you had to basically sum up this weighted list of factors and look at the total score that way. Nomograms display those as easily on paper as anything I could find. That was my attraction to that approach. Is job number one is accuracy. Now let's do the best we can with ease of use, versus flipping it on its head and say, I need an easy to use system that I hope is accurate, if I even care about accuracy. And a lot of times folks didn't.
Thank you. That, as far as I know, is the most universally used nomogram for prostate cancer. And congratulations on having done it. Now you've come forth with a very timely predictive modeling manuscript in CHEST, which is, of course, used for COVID-19. In case not everybody who's seeing and listening to us today has read it, could you please outline the study and the important findings?
Sure. Yeah, so as soon as, and I'm sure you encountered the same thing, but as soon as COVID started to break here, the whole team basically went on nonstop COVID projects, 7 days a week, 24 hours a day. Everything else, let's just put it on hold. And so when we started going down this route, we quickly first made a registry to capture everyone getting tested. We opened the drive-through testing very early in that process, and so we were quickly collecting quite a bit of data. But the whole thing was new. This was the real challenge here. Was usually I'm modeling whatever, prostate cancer, or breast cancer, colorectal cancer, something where there's been plenty of studies, plenty of registries. You can look at lots of prior research, figure out the risk factors that you'd probably start with. And here it's like, well, we got nothing. So good luck, and hopefully you collect the right things. So we began putting the registry together. And once we got started to get at least somewhat of a critical mass, we laid out kind of a series of prediction models that we thought would be important. First one of those being this one that came out recently in CHEST, and that's simply predicting the probability that you will test positive if you get tested today. Big problem, of course, is we don't have enough testing kits and other resources to be able to test everyone, all the time. So we've got to prioritize based on something. So potentially a factor in that prioritization would be, Frank, just simply, are you even likely to be positive? If you're vastly unlikely to be positive, we probably don't need to, burn a test kit on you, and we should reserve them for those at reasonably higher risk. So that was the first of the models that we started making, of course, recognizing that it's not just about testing positive, because most people, fortunately, who end up having the virus do quite well. But unfortunately, many don't. So that pushes us into the second model, which is, given you test positive, are you likely to be someone who's going to get in trouble here, end up in the ICU, on a ventilator, something of that nature? And so this led a series of models. Those others are all still in practice, but this first one is now out. And what was interesting here was it really plays into the next model too. Is kind of the perception that if I am young and healthy, I don't even need to even think about this problem. And it's some of the machine learning techniques are well suited to find a decision rule like that, because they explore the data very thoroughly and they look for those kinds of algorithms that would play out in the data. And couldn't find that. Frankly, couldn't find that even in the model that predicts the serious serious virus too. It's not as simple as, if your age is over X, and you can pick any X, there's nothing magical about any cutoff that I can find. Or if you have this specific comorbidity, again, I can't find that either in our data. It's more of this, again, back to this concept of a weighted sum. It just kind of all adds up. And yes, older age is worse. And yes, there are many different comorbidities that again, just kind of add up, but it's not a single easy to use thing. It's kind of a sum of risk, which it makes sense. It's just harder to use, but it plays into the nomogram solution pretty well, since they're well positioned to present those. But ultimately, once we got, we used the Cleveland Clinic, Cleveland or Northeast Ohio data for developing the prediction tool, the model, and then we used Cleveland Clinic, Florida as a validation set, and did the testing with folks folks down there, and found that the tool did pretty well. In some sense, better than I expected, because this is a tough setup here, not just because we don't kind of know exactly what the risk factors are, because this is so new, but also because it's such an evolving state of affairs. Here we've gone through phases of testing, from an early standpoint where we weren't picking up many. We were testing a lot, not picking up that many positives. Then we constrained it because we couldn't keep going at that pace, constrained it to a higher risk setting. So we were enriching for positives there. And then now, if you come in to get your, teeth cleaned, you have to be tested first, regardless of symptoms or anything. So now the prevalence has shifted way low again. And this is, I'm going to have to keep an eye on that, because this could throw some things off. But seemed to go pretty well. Better than chance, better than no rule at all, better than something ad hoc in terms of who you put into the high risk bucket versus not. So we have it, basically it turns out to be a long equation with many different features, including age and some blood tests results, some comorbidities, some social determinants of health in terms of the city block where you live. Is it a densely packed one or not? For example, plays into that. And made this nomogram tool that's in the paper. We also put it up on the web as a risk calculator that's online. It's free. It's on our risk calculator repository. Again, though, meant for clinicians. It's not a patient-friendly tool. I mean, it makes a lot of sense. It's most patients could probably, use it properly, but it's not designed for that, because it doesn't really explain anything or hold your hand. It's meant for an MD who knows exactly what, this blood test is and that kind of thing, and can make sense of it for ease of use. We're in the process of getting it integrated into Epic. So just as you normally take care of the patient, you'll have this risk prediction as a byproduct, and you won't have to do any extra step like go to our website and enter those things. But I guess what else was interesting about this was thinking about, what do you actually do with it now that you have it? The easy part is, okay, here's your model. It predicts the probability between 0 and 1 that you, Dr. Wexner, will test positive if I go and test you today. And now what? What's the rule? Who do I, restrict to, or who do I maybe use the rapid test? All sorts of other issues come into play that would drive that whole algorithm for exactly how you integrate it. So that requires some more thought in terms of even just the cutoff, because you're gonna miss folks depending on where you draw the line, and you have to think about the trade-offs there too.
Thanks very much, Mike. And unfortunately, time doesn't permit us going into the nuances of the article. I found some of them fascinating about melatonin and
Right.
polysaccharide vaccine things. So I'll leave our audience with those teasers that there are some very interesting tidbits in the article in chest, and I
go read the
people
paper.
to read it and to go to the risk calculator repository and play with the tool a little bit. Thank you for your expertise and your time.
Thank you. Great to see you again.
Likewise.